Good evening, everyone. Thanks so much for joining us for Facebook Live this evening. Tonight's topic is lung cancer, and we are here with two of our finest at Mon Health, Dr. James Frederick Littles. He is a radiation oncologist here at Mon Health Medical Center. We have Dr. Allison Sela, and she is a pulmonologist at Preston Memorial Hospital. Thanks so much for joining us tonight.
It's my pleasure.
Yeah, we are so excited to have you. Dr. Littles is a returning guest. And Dr. Sela, this is her first Facebook Live, and we're really looking forward to tonight's questions. So make sure you get your questions ready, and we're excited to answer them. So again, tonight's topic is lung cancer, and we thought the best thing to start off with tonight is to get to know you a little bit. You know, ask you what led you here to Mon Health, what your specialty is, and really what kind of just, again, you know, led you here to Mon Health in general. Dr. Littles, you want to start off?
Sure. I grew up in South Carolina and spent a lot of my professional years in Michigan, with the University of Michigan, and trained at a large hospital in Metro Detroit. I was traveling, bringing my kids back and forth to school, and so Morgantown, West Virginia, knew it was a university city, and as I was looking to get to warmer weather, I heard from a recruiter, and I said, the university city, with my affiliation at the University of Michigan in the past, I knew the advantage of being there, and I decided to take a look at the opportunity, and one thing led to another, and here I am. And one of the things that's clear about Mon and its institutions are a very, very supportive and progressive community, which makes it a great place to practice.
That's great, and your patients adore you. So we're so happy to have you here.
Thank you for saying that.
All right, yes. Dr. Sela.
Well, I grew up in Ohio, and I went to the University of Toledo for medical school. And after that, I came to WVU for my residency and stayed on for my fellowship training, which I trained in pulmonology and critical care. And met my husband while we were in training, and he's from this area, and so we decided to stay in the area. And I found a great opportunity at Preston Memorial where I could treat patients in a local community, in their community, so that they don't have to travel to get the health care that they need.
Talk about a beautiful hospital too.
It is.
Preston is gorgeous.
Beautiful.
Wow.
Yes.
Thank you so much. We're so excited you're here. So our first question, it's a really great question. Low-dose CT screening. What is it, and what happens if a patient isn't covered by insurance? If you could just better explain really what it is. You see a lot of billboards about it, a lot of people talk about it, but not a lot of people know what it is.
So a couple of years ago, the agencies that help for cancer screening came out with recommendations that we should be screening patients for lung cancer. We screen patients for breast cancer, we screen patients for colon cancer. What can we do to try and identify lung cancer at an earlier stage? And they looked at doing different types of screening processes. They found that chest x-rays really didn't work, but what they did find that worked was something called a CT scan, CAT scan, as is also known. And they came up with a low-dose CT scan, and what that means is that it gives you a low dose of radiation. So it's not going to give you as much radiation as a regular CAT scan, but it does give you enough in order to be able to identify different structures in the lungs. And with that, what we're looking for is something that's abnormal. And our hope is that by screening patients, that we can identify lung cancer at an earlier stage, where it's hopefully much more treatable and even curable, rather than waiting for patients to come to us with symptoms of lung cancer. Okay. So the criteria for a low-dose CT scan is sort of in flux right now. Traditionally, it's been patients that are ages 55 to 77 who have smoked, who are either our current smokers or who have quit smoking within the last 15 years. And these patients need to have smoked what we call 30 pack years, which means 1 pack of cigarettes a day for 30 years, 2 packs of cigarettes a day for 15 years, 30 pack years. Okay. Earlier this year in March, they came out with new guidelines that extend this range, and what they want to do is test people that are ages 50 to 80. And then they also changed down to 20 pack years, which means 1 pack of cigarettes a day for 20 years, or 2 packs a day for 10 years. And so again, those are sort of in flux, which means that the societies have said, yes, we agree, that's what we should be doing, but the insurance companies haven't quite followed suit yet. And so we're sort of in between these two sets of guidelines at this point. We're hopeful that CMS, which is who's in charge of Medicare and Medicaid, We'll make a decision sometime in February, and so hopefully we'll have these new guidelines. Some of the private insurance companies are already following these, and so we go patient by patient to determine, what their criteria are at this point.
Okay, perfect. Alrighty, thank you. Next question, along with low-dose CT screening, who is eligible to be screened?
I think, as Dr. Sela said, the original study was for patients 55 to 77 and a 30-pack history of cigarette smoking. That certainly has been proven. There are other studies that look at a broader range, but that tight window between 55 to 77, major study in this country, over 50,000 patients, showed a 20% reduction in what we call lung cancer mortality. And the reason why lung cancer screening is so important is that lung cancer is the deadliest cancer known to man. And actually the lung cancer rate for West Virginia is second in the nation behind Kentucky. And 25% of West Virginia adults smoke cigarettes. That is the highest in the nation. So when you talk about lung cancer screening, it certainly has an opportunity to have tremendous, impact in this country, and certainly in West Virginia.
Wow. And the studies prove it.
Oh,
yeah, wow.
There's no doubt about it.
Okay, what is the importance behind screening for lung cancer? What should I look out for when it comes to lung cancer? Really, what are the symptoms?
The biggest thing about what makes lung cancer screening important is that lung cancer can be without symptoms for a long time early on. So the data shows that if you catch a lung cancer in its early stage, which ideally we would do in the lung cancer screening program, there's a 60 to 70% chance of what we call 5-year survival versus 10 to 20% chance of 5-year survival if you catch lung cancer late. And there's been speculation that if all the people in this country that are qualified to be screened, we would save 1,000 to 2,000 lives per month with lung cancer, and that's a lot of people. That is a lot of people. Depending on which studies you read, some say 1,000 lives a month, and some say up close to 2,000 lives a month. So the study is pretty clear. It's a very large study, 50,000 patients, shows that low-dose lung cancer screening saves lives. So that's why we're here. I mean, we're actually tackling the big gorilla in the room, the deadliest cancer known to man, and the literature is pretty clear. Lung cancer screening saves lives.
So how do you go about getting screened? Who should you contact? And really, what's the process afterwards?
So that is something that can be done if you see a pulmonologist. They can certainly order that, but your family doctor can order that as well. Okay. If you are a current smoker, if you've quit smoking within the last 15 years, you definitely should talk to your family doctor, or if you see a specialist, a lung specialist especially, they can help you with that as well. Okay.
And also over the internet, monhealth.org /lung cancer, monhealth//lung cancer.
Great website. 100% there. Alrighty. Okay, so a lot of patients in West Virginia need to call the quit line. How do they go about that really? What's the information behind the quit line?
So the quit line is, it's a hotline for patients that are smokers, where there are trained counselors that will help to give you information, advice, counseling regarding how to quit smoking. Most patients, or a lot of patients in West Virginia, their insurance requires that they've had some sort of formal counseling or speak with somebody about that. And so what they usually say is call the quit line. And the phone number for the quit line is 1-800-QUIT-NOW. They also have a website, which sometimes I think is a little bit easier to navigate if you have internet access. And again, there's a coach that will work with the patients to develop a personalized quitting plan, which may or may not include the use of nicotine replacement or other types of medications to help you quit smoking.
Okay, great, thank you. Next question is, what are the different options for lung cancer, treatment options, excuse me. How do I know if treatment is working?
I think the gold standard for treatment of lung cancer, specifically early lung cancer, is surgery. That has been there for years, and the great thing about that is surgical techniques have have improved. So the gold standard for early lung cancer is surgery. There are other, for locally advanced lung cancer, there are other options, radiation, chemoradiation, but the gold standard for early stage lung cancer, and that's what we want to find with the lung cancer screening, is surgery. But I want to go back to smoking cessation, and I've often told this story when I was with the University of Michigan. We were at Cancer Center Grand Rounds, and one doctor came in and presented to some of the finest cancer doctors on the planet. And he said, if you ever want to impact patients' lives, encourage your smokers to stop smoking. That will save more lives than any research you could ever do. So the other reasonable method and sometimes effective method of smoking cessation is something called hypnosis. I've had several patients to be hypnotized and quit smoking. But the best way to quit, of course, is cold turkey. Then there are medications, but also things like hypnosis can be very effective. Very effective indeed.
Have you found that quitting cold turkey has been effective?
There's a subset of patients that can do that. And I always say that nothing great in life is ever easy. And nicotine is a hardcore cocaine-like addictive substance. It is more addictive than heroin, more addictive than alcohol, and more deadly than alcohol. If you read the literature, it will tell you that every minute in this country somebody dies of cigarette death. Every minute. 1,200 people a day. Unbelievable. So it's quite a product.
Wow. Okay.
To put it mildly.
Next question is, not all lung cancer is related to smoking. What else can really cause lung cancer?
That is correct, but let me be real clear. 80 to 90% of all lung cancer is cigarette related. A distant second, and I mean a distant second, is radon. And radon is somewhat prevalent in West Virginia, but I want to be real clear. It is the cigarettes. We're not going to end this Facebook Live thinking about a whole lot of different things when the elephant in the room is cigarettes. So certainly radon is second, but radon is a distant second. It is something that most homeowners will have as a part of their inspection and work with that as they see fit. But it's the cigarettes.
Okay. Next question is Monarch. What happens if you could explain what Monarch is, and what happens after I get a positive on my low-dose CT screening? So really two separate questions.
So when you go for your low-dose CT scan, what will happen afterwards is that the patient will receive a letter saying this is what we found. Their provider will also receive the same letter, and you should talk to the person who ordered the CT scan for you to sort of coordinate and say, what does this mean? Where do we go from here? Our hope is, for the vast majority of patients, everything will look good. And in that case, the recommendation is to get another low-dose CT scan in 1 year. Okay. The recommendation, like a mammogram, is every year. So that's our hope. If by some chance that is not what happens and you have a finding on your CT scan, it really depends on what we find. And we use size criteria as our guide as to what to do next. And so if this is a small nodule, we can watch it with another CT scan. It may be in a year, it may be in 6 months, it may be sooner than that. We may want to get some additional types of imaging, such as a PET scan, or possibly a CT scan with contrast or something like that. If it's a big finding, if we find a mass or a larger nodule or something like that, then usually the next step is to get a piece of that tissue in order to determine what that is. And so one of the things we can do is a PET scan, but we can also do several different types of biopsies on this nodule. We can do ultrasound-guided biopsy, where we use an ultrasound probe to locate the nodule. We can use electromagnetic techniques. And then one of our newest technologies is something called Monarch, which is a robotic-guided technology. And it's pretty fascinating. And what they do is they're able to look at the nodule on the CT scan and then find a pathway through the airways to get directly to that nodule. So it's almost like a GPS for the lungs. So what they're able to do is take a scope insert it into the airways, and then drive it right to that nodule where they can stick a needle in and biopsy that. And that will give you, it really is, it really is.
Safe and effective.
Yes, yes.
When it's appropriate, for sure.
And just, I remember seeing Dr. Chowdhury using it, and we had a Facebook Live focused on Monarch, and one of the questions was, did you play Xbox when you were a kid? Because it's unbelievable how they're able to do that. I mean, they just have a remote control, and it's just, I can't believe how fine the probe is.
The robotic technique has been used for years in several other specialties, and it's finally come to the pulmonary specialty, and it's absolutely amazing what they can do with it.
Wow, amazing. All right, we've had a lot of questions about Monarch, so thank you for addressing that. Okay, how does treatment affect my daily routine? That's a good question.
How does treatment?
Treatment overall for lung cancer? I know there's different forms of
Yeah, it certainly depends on what treatment does. Surgery is classically a one-time procedure. There's preoperative assessments and postoperative assessments. Daily radiation for lung cancer, and I say that lung radiation treatments are in essence high-tech target practice. We use radiation to damage the DNA of the cancer cell, and when the cancer cell tries to divide, it dies. So the side effects of lung radiation are depending on the part of the lung that's being treated. We have, one of the things that attracted me to MON is we have a multi-million-dollar department with state-of-the-art equipment, and when I got here 2 years ago, I asked for one or two small things, and it was approved right away because, again, a very supportive community. So we're able to target the radiation with very sophisticated planning systems, state-of-the-art equipment, and minimize the side effects. So for example, if a lung lesion is near the center of the chest, we have to be concerned about the heart and the esophagus. If it's near the periphery, the side of the outside, along the periphery of the chest, we're concerned about the ribs and the chest wall. But daily treatment is classically 30 minutes a day. That's including setup time and everything. So radiation, as I tell people all the time, is simply a high-tech target practice. And so we set them up, and they start the next roughly a week later. We put everything in our planning system, and everything's customized based on the lesion and the proximity to what we call organs at risk, which could be the heart, the esophagus, or the spinal cord, or the chest wall. And so it's a little different than the throughput of diagnostic radiology in that when you treat someone every day with radiation, you're sort of in the perfection business. You're not in the timeliness business. So sometimes there is throughput pressure, but we don't have that. We have perfection pressure because we want to hit the target right on target each and every day with our planning system.
Thank you.
Sure.
Next question is, how do I know if I'm a good candidate for surgery?
Well, that's classically a question with the help of the pulmonologist, and we have some things called pulmonary function tests, and the surgeon will first take a look at the lesion and take a look at the patient's what we call comorbidities, whether they have a good kidney function, good heart function, and then do what's called a pulmonary function test, which looks like is the functionality of the lung. If they can tolerate removal of a lobe or the entire lung, and those type of things that thoracic surgeons assess. And they usually make that decision in a classic, in general, multidisciplinary form with input from the pulmonologist and the surgeon.
It certainly depends on the type of surgery that they're planning to do as well.
Yes.
The Monarch procedure is very, very much more low risk than going in and taking out a large portion of the lung. And so, the patient's day-to-day activities and what they can do definitely play a role in that as well.
Okay.
And this, again, is where smoking comes into place. And that patients that are non-smokers or patients that have quit smoking more than 30 days prior to surgery do better than patients that are still smoking.
Gotcha. Okay, thank you. Next question is, does family history play a role in being diagnosed with lung cancer?
I think I would consider a smaller role. There's certain other malignancies that have a major genetic predilection. Lung cancer does not appear to be one of them. When we think about lung cancer, I want us to think about cigarettes, and cigarettes again.
Thank you.
Sure.
Next question is lung cancer more common in men or women? Good question.
Well, historically, it was more common in men. But as we've had gender equality and things to fortunately move forward, more and more women through the 50s, 60s, and 70s were cigarette smokers, and now the ratio is close to equal. But 40, 50 years ago, it was definitely more prevalent in men and women. And it's interesting, the same risk factors for lung cancer are there for certain head and neck cancers, but it appears that the ratio of men to women for head and neck cancer is less, and the theory there is related to actually hormonal differences. Within the airway, upper airway, the larynx and voice box, there's what we call androgen receptors, which men have and women don't, and that leads to the ratio difference between men and women for head and neck cancer among smokers. But lung cancer is historically been higher for men, but women have unfortunately gained ground over the past several decades.
Okay. Interesting, thank you.
Sure.
Next question is, how will I know if my cancer came back?
Great question. When we treat patients with lung cancer, we follow them with CAT scans and PET scans, and as medicine progresses, more accurate diagnostic studies are available. So we're able to follow patients a lot more efficiently now, because just like technology in cars and boats and trains have progressed over the past 30 years, same thing for diagnostic medicine, same thing. So we follow them with classically CAT scans and sometimes even PET scans.
Okay.
Yeah, and that's what we do.
Okay.
How we follow our patients.
Next question, where can I go to learn more?
MountHealth.com/lung cancer.
Yeah, great website. Has a lot of information on it. Also, next question, are nodules found on the lung always cancerous?
Definitely not.
Okay.
Definitely not. And from what I've heard, being in West Virginia for just 27, 28 months, within the mountains, there are a lot of benign diseases that look, walk, and talk diagnostically like lung cancer and end up being, benign infectious type processes. And Dr. Seela may be able to speak more of that.
Sure. I see patients all the time that have gotten a CT scan for some reason or another, and we find a nodule, and not all of them are cancerous. There's certain patients that have risk factors for cancer, again, smoking being the top, but other things that these nodules can be is infection. It could be a scar from a prior infection. Sometimes lymph nodes show up this way. So there's lots of different things, but our goal as your physician is to really rule out what's the most serious thing, the thing that could cause death or other type of serious injury. And so it's always at the top of our list to make sure that we're not dealing with cancer.
Okay, thank you. Next question is, what are some tips and tricks on how to quit? What are the options that you usually give your patients? Good question.
Cold turkey, nicotine patch, other oral medications, and again, hypnosis. Yep. And I think I've read also acupuncture.
Oh, okay.
Yes.
Okay.
Yeah. So, cigarettes are such a daily, daily habit.
Sure.
We try anything and everything.
Yeah.
We want anything that works for you, works for you. Yeah, absolutely.
Absolutely. I often try to identify with my patients what is causing them to smoke. Sure. Is it stress? Is it a habit? Is it the hand-to-mouth habit that they have? And if so, what can we do to replace that? Do they knit? Do they have an adult coloring book that they like to color in? Yeah. Can they eat carrot sticks or something else, to mimic that, but to not have the cigarettes there? If it's stress, can they go out for a walk or do something else to manage that stress? And so I like to try and personalize, the approach for the patient based on what is driving them to continue to smoke.
That is great. Okay, thank you. Next question is just one more question. If you could just reiterate, what factors could contribute to me being diagnosed with lung cancer? What are some risk factors?
Well, the biggest one I think we've covered tonight is smoking, definitely.
Yes.
And unfortunately, the men are still at a higher risk, although again, women are catching up. Those are really the biggest ones. I think, you know, some occupations do play a role. You know, if you're exposed to things like asbestos or other types of smokes, that definitely can play a role. But really, you know, smoking is going to be the big one.
Alrighty.
Yeah, it's 1, 2, 3, and everything else is a distant 5.
Right.
Thank you.
Sure.
Wonderful questions tonight. Dr. Littles, Dr. Sela, thank you so much. We really appreciate having you here tonight.
It's our pleasure.
Thank you.
Thank you for all you do.
Yeah,
Have a
thank you.
wonderful evening, everyone, and thank you so much for all of your questions. We'll see you next month.